All right, a couple minutes early, but going to go ahead and get started with our next talk. So it's my pleasure to be able to welcome Dr. Jasmine Marslin. She's an assistant professor of medicine and infectious diseases. She's also the co-director of the Digital Innovation and Social Media Strategy for the Division of Infectious Diseases and an associate medical director for the Antimicrobial Stewardship Program at the University of Nebraska Medical Center. And we are excited to hear her very timely and important presentation this afternoon. Dr. Marcelin, the floor is yours.
Thank you. Thank you for the introduction, Dr. Beachy. So in gratitude, I would like to start by acknowledging that regardless of the location from which we are accessing this virtual Nebraska ACP meeting, we are guests living on lands represented by Native nations whose sovereignty, governance, and treaty lands existed long before the creation of the United States of America. So as we have progressed through this pandemic, it became clear that we really need to begin and continue discussions and conversations relating to the very disturbing racial and ethnic disparities that we're seeing emerging from cases, hospitalizations, and deaths due to COVID-19. The objectives are listed here, and I have no disclosures other than to say that this is a topic that can and will make us all very uncomfortable. But I invite you to step into the tension of discomfort with me, and hopefully we'll all come out of it with a shared understanding of our collective roles in health equity. So briefly reviewing the general numbers, updated as of yesterday, October 23rd, worldwide, we are seeing more than 42 million people who have been infected with COVID-19, and over 1 million people have died. In the United States, over 8 million people have been diagnosed with COVID-19 and over 200,000 deaths, approaching 225, 250 deaths as we get to the end of October here. In Nebraska, over 62,000 people have been diagnosed with COVID-19 with almost 600 deaths. So we've identified a lot of risk factors for severe disease due to COVID-19. We've, over the last several months, developed multiple testing modalities, and we've tested and had approved different treatment options for COVID-19. But we have seen some very clear and disturbing disparities unearthed. In this country and in many other developed countries around the world, we are no strangers to disparities and health inequity. So let's start by talking about what are the definitions of health inequity and health disparities. So when everyone has an opportunity to be as healthy as possible, we can say that there is health equity. But when there are differences in outcomes and the causes of those differences, according to different races, amongst different groups of people, these are health disparities. It is important to note that health disparities can also occur amongst any number of groups of people, not just along race and ethnicity lines. So for example, there are health disparities amongst transgender women and other LGBTQ+ community members in HIV and sexually transmitted infection outcomes. People from low income and rural communities and indigenous communities with health inequities and health disparities relating to hypertension, diabetes, etc. So the common threads amongst these different groups of individuals experiencing these disparities relate to structural inequities, which we will discuss a bit later. So in the next few slides, what we'll do is we'll get into the mindset that we need to be able to discuss the why of disparities by first recognizing how profound they are in the first place. So as we look at this particular slide here, we can see that the health disparities and health inequities can occur across a number of different areas and populations. And we really need to consider interrogating our role as healthcare professionals in propagating health disparities. There's a precedent for disparities in how patients fare during outbreaks and pandemics. During the 1918 influenza pandemic in cities across the nation, Black people struck by the flu were often left to fend for themselves. They received substandard care in segregated hospitals where they would either be relegated to close quarters in basements, which would populate the spread of influenza, but also there were situations where they were only allowed admittance to Black-only hospitals, which were under-resourced. So the case and hospitalization and mortality data for influenza is not as complete with all of the race demographics. And this might be because they were not reported consistently. And also because of segregation, less data would have come from Black hospitals. And nevertheless, though, we see some similar threads. Even in 2020, as we know that there are some county hospitals providing care to primarily non-white populations who have lower standards of care and worse health outcomes for those communities. So it's no coincidence that we're seeing the biggest disparities, for example, in some of the inner city boroughs, like what we saw earlier in the pandemic, inner city New York City, boroughs south side of Chicago, Detroit, in areas where those historical segregation has been seen. In non-infectious disease examples, we have a number of examples of disparities amongst different cancer types by race or ethnicity. And in the US, there are stark differences in maternal mortality, with African American women being more likely to die from their pregnancies than white women, regardless of race, education level, or socioeconomic status. And there certainly is a history of long race-related health disparities in this country that's directly related to racism and white supremacy. So let's take a moment to consider the impact of this reality. Today, we know so much about the different stages of syphilis because in the 1930s, 400 Black men were unethically recruited into a federally funded study, knowingly withholding syphilis treatment from these men to study its long-term effects. So those men were, of course, not the only ones that were impacted by this. All of their partners and their children were subsequently affected. And it was only when there was public discovery and outcry of this unethical study that led to its eventual discontinuation. But this also led to a profound level of distrust and mistrust in the medical community that we as the medical community were the ones who mishandled that trust amongst the Black community. And what that results in is that elders who are old enough to remember a Tuskegee study occurred in their youth may cite it today as reasons for not wanting the flu shot or other immunizations. And here we are in 2020 in the middle of a pandemic, and the memory of this study is responsible for a lot of mistrust in the Black community, including any skepticism about any potential vaccine that may emerge to prevent COVID-19. There are also similar stories of betrayal amongst Latino and Native American communities, leading to ongoing distrust of healthcare professionals and institutions today. In fact, there is a dark and terrible history of forced sterilization of Indigenous women and girls on tribal land, sanctioned by Indian Health Services in the United States and Canada. And we've been seeing over the last several months, weeks to months, reports of forced sterilization and unethical practices at ICE detention centers that are holding predominantly Latina women. So what are we seeing with COVID-19? I want to particularly draw attention to the disparities in the Indigenous community, which closely mirrors that of the Black community. But Native Americans are often erased from discussions about healthcare disparities. What we're seeing here is that 1 in 950 Black Americans has died from COVID-19 thus far. 1 in 1,110 Native Americans has died. 1 in 1,360 Hispanic Americans has died from COVID-19. What that means is when we're looking at the rates and age-adjusted mortality for death from COVID-19, we're seeing that people from these three racial and ethnic groups are dying at rates that are over 3 times higher than that of the white population in the United States. A recent study from the Washington Post reported that 1 in 3 Black Americans know someone who has died from COVID-19. So I'm a Black American and I'm also an infectious diseases physician. So that means I know many people who have died from COVID-19, and that is to be expected from my job. But what you may not have expected, however, is that even excluding my professional connection with patients dying from COVID-19, I too have a personal connection that has made me a part of that statistic. Several months ago, one of my cousins, barely in his 50s, died from COVID-19, and he was young, he was educated, and he never made it to the hospital before it killed him. So thinking about the death and destruction that this is caused by this virus, it really hits differently when it is somebody that you know, someone with whom you ate, you went to church, and you laughed, somebody who watched you graduate from medical school. And if you hear sadness in my voice and catch a hint of sadness in my face, it is because this is a very sad reality when you consider the proportion of those affected. For example, Black Americans represent only 12% of the country's population, yet account for over 24% of all COVID-19 deaths. Here in Nebraska, we see that a greater proportion of Latino and Hispanic Nebraskans have died from COVID-19, very closely followed by Black and Indigenous persons. And zoomed into Douglas County, we continue to see these disparities play out in extremes among the Hispanic community, with clusters particularly surrounding meatpacking communities. And as we look through the census of our COVID units at Nebraska Medicine, these are the distributions that we see. And the spike in the cases amongst Asian population community members that we're seeing reflects the high Karen refugee community that we have here. And the most stark realization one has when looking at COVID-19 list is that the majority of our patients that are in the COVID units do not speak English as their first language. So why is all of this happening? Why are we seeing all of these health disparities in COVID-19 and in other health disparities? I wanted us to take a few moments in the chat to hear your thoughts on why this might be happening. So I'm going to pause here for a second, and if you have access to the chat, please share your thoughts and your comments on why some of this is happening. So I'm seeing one of the responses already saying fewer resources to avoid having to use family and friends for childcare and separated housing, hazards or exposures related to employment. What else? Some of the meatpacking plant patients stated no PPE at work, and that's really interesting. There's been a lot of work that's been done through UNMC that has been talking with our meatpacking plants and getting some of this information from them. And there's definitely a lot of responses saying that they don't have a lot of access to PPE, or they may be told that they should come to work anyways, even if they don't feel well. There's a lot of great work that is being done at UNMC trying to find out some of these reasons. Communal living. So all of these, the discussion that everybody is throwing into the chat really kind of lies on what are the environments and what are the experiences of the individuals that are being impacted. And I'm glad that we are all sharing some of these. I'm going to move on, close this chat here. Okay. So it's related to structural racism, right? All of these things that we shared a little bit are related to structural racism. So now that we've discussed the numbers and of the disparities and details, these next few slides will discuss that why that we were talking about through the chat in order to help us to develop that skill set of understanding and identifying structural issues that may impact our patients. And it's important for us to be able to contextualize these numbers to avoid perpetuating myths about these disparities that assign blame to the very populations that are disadvantaged. So first, some definitions. The first one you may have heard of, unconscious bias, and we don't fully explore this in this talk. It refers to the unconscious beliefs that people have about other people. And often those beliefs are shaped unconsciously by the systems that perpetuate and reinforce inequities. So I think it's important for us to understand the historical and societal context that shapes unconscious bias, and that it comes and stems from the impacts of structural racism. So what do we mean when we say racism? Here you'll see three general types of racism described. So interpersonal racism refers to an individual's personal beliefs in the superiority of their race to another's race. And this is also related to historic structures of power that have reinforced these beliefs. These beliefs are then acted upon and expressed in hate speech, hate crimes and violence, overt discrimination based on race as expressions of power. Institutional racism results when individual people have the power to implement policies and procedures to then systematically oppress others without the need for individual acts of racism. So for example, if a hiring process is set up so that only candidates from an area with a certain GPA are accepted for the job, and people from marginalized groups rarely achieve that GPA because their education system lacks resources to support those students, they could be effectively excluded from that job without anyone ever having to make a decision to not hire them purely based on their race. And then structural racism refers to the ways in which these historical and contemporary racial inequities in outcomes are perpetuated by social, economic, and political systems, including the mutually reinforcing systems of healthcare, education, housing, employment, the media, and criminal justice system. So what it does is it results in a systemic variation in opportunity according to race or ethnic background. So for example, racial differences in access to healthcare. And when it comes to the African-American race in the United States of America, these structural inequities have had over 400 years of historical context in this country. From slavery to emancipation and Reconstruction, to segregation and Jim Crow, to desegregation, the civil rights movement, and today's post-civil rights America, the impacts of structural and societal constructs have permeated through to where we are today. And for those of you who recall reading in high school George Orwell's 1945 novel Animal Farm, the premise of that novel is unfortunately applicable to today's society, with that haunting supremacist declaration that all animals are equal, but some are more equal than others. And that is the reality that many of us who live in Black and brown bodies have to deal with on a daily basis. So these social, economic, and political structures embedded in our society interact to create these structural and social determinants of health, and those in turn impact health outcomes. And while a number of other factors interact to affect an individual's overall health, the largest impact to an individual's health comes from those socioeconomic factors or the social determinants of health. So as we think through these structural and social determinants of health, I wanted to provide a few examples of how these disproportionately disadvantage minority populations. So let's use the example of Omaha. So the figure on the left is a redlined map of Omaha from 1936. And the figure on the right is a racial dot map of Omaha based on the 2010 census data housing that was used. And so housing that was undesirable was allocated to minority populations in the early 1900s. And so the after effects of that are still felt today, as many of the folks from these neighborhoods don't have the resources to be able to leave the areas where they grew up and have built community. But it also means that these communities are under-resourced when we consider the way that our city of Omaha remains functionally segregated to this day. So it shouldn't be a surprise that the communities that are experiencing disparities in COVID-19, and particularly those that were really hard hit in the beginning, are some of the communities that are in those same redlined areas, where they may not have as readily available access to healthcare because of lower health insurance rates, or more housing instability, or multi-generational home situations, or food insecurity and reliance on communal meal opportunities, or inability to work from home because they're working in essential jobs. And for anybody who would like to have an inside look into what these structural barriers may be like for minorities living in Nebraska, I advise you to check out this documentary out of Omaha that follows some twin brothers from North Omaha as they try to make a life despite some of the odds that have been stacked against them. So let me be clear. SARS-CoV-2 and COVID-19 are not racist. I'm not saying that. But people can be, and systems and society can be. Unless we think and believe that America is winning in this problem, we will still also find, if you look for the data, you will find similar findings in the United Kingdom, where the population of the proportion and distribution of underrepresented individuals is similar. And there is a very similar history of power and structural oppression in the UK, as we know how closely entangled the United States and the United Kingdom have been. One can't discount the disparities in underlying medical conditions that are associated with higher risk of severe COVID. So this is responsible for hospitalizations, for intubations and deaths. And we know that heart disease, obesity, and diabetes are risk factors for these higher risk outcomes. And these conditions are overrepresented in Black, Hispanic, and Native American communities relative to their share of the population. However, generational patterns in development of these comorbidities is not in and of itself proof of any biological explanation for these disparities. What it is a manifestation of the systemic differences in food insecurity, in housing insecurity, in low income status that predispose minority groups to have worse health outcomes. Minority populations in Omaha specifically have differential access to the basic needs to remain safe during this pandemic because of where they live. And early zip code data lined up almost perfectly with that historic redlining that I showed you earlier. This McKinsey report showed that Black Americans are disproportionately represented in 9 out of 10 of the high contact essential services. And only 20% of Black American workers can actually work from home. And furthermore, most of the lower income essential jobs are the ones who are most likely to be fired or furloughed during this pandemic and then likely to suffer lost wages. So when we're thinking about the why and what is putting individuals at risk, we also have to consider the structural and systemic issues that are making it so that people feel like they have no choice but to continue to go to these high-risk jobs. And then we have these directives that we tell people as far as how can they protect themselves from spread of the pandemic. Many of these directives we give to the general population are not really designed with minority or vulnerable populations in mind. How many of our patients from minoritized communities have identified a primary care practitioner or have easy access to testing centers? Drive-through testing is an amazing breakthrough in many states, including our own, but if people don't have access to vehicles, how will they get tested with a drive-through testing approach? Early in the pandemic, we were seeing recommendations to just use anything to cover your face if you don't have access to a mask. Wear a bandana across your face. The reality is wearing a bandana over one's face can prove to be fatal for many Black men. How can this be the recommendation for 13% of the population when they are likely to be killed by either police or concerned citizens because they appear to be threatening when they're wearing their bandanas? Imagine a person who does not have access to a mask, a Black man who walks into a bank to cash his check, and people have their first initial response of him. Do they think that he is there to rob the bank or cash his check? The most likely outcome of that situation is somebody calling the police on him, even though that he was trying to protect himself and them by wearing what he had access to him, which was a bandana. Then we consider the Hispanic or immigrant populations. How do we expect them to understand what the pandemic means, how to protect themselves if we only provide instructions and education in English? And then when we consider washing our hands, a 30 to 40% estimation of people who live on Navajo reservation in Navajo Nation do not have access to running water. So how are they expected to maintain hand washing that's required during the pandemic? We really need to think about the directives that we're giving to our communities and consider them in the context of the resources that are available and the risks that are available for our communities. And so as if it wasn't enough to be living in a society where you are at higher risk of dying from a deadly virus caused by a pandemic, Black people specifically in this country have also had to contend with being at higher risk of dying at the hands of police and others who deem their Black bodies as undeserving of empathy, due process, or life itself. So in the middle of a pandemic, people everywhere are rising up in protest. A low flame that has been smoldering over the years stoked into a national blaze by the videotaped lynching of George Floyd by Minneapolis police officers. Why are people willing to venture into a pandemic to protest against police brutality and racism in this country? Because they realize that both are killing Black people at alarming rates. And as we previously discussed, systemic racism is very much the underlying foundation of the healthcare inequities that have led to the disparities that we see in COVID-19. So what can we do about this? In the next few slides, as we wrap this up, I wanted to talk about the things that we can put into our tool set for addressing these disparities. So we'll talk about COVID-19 disparities, and then we'll talk about how to discuss broader solutions to reset society. This is a great image that's created by the Association of Black Cardiologists addressing disparities and solutions in a recent article published by Haynes et al. So there's a lot of great ideas in this infographic, and two things that I think are particularly important are protection of essential workers and prioritized testing. However, some additional items that I would think that could be also done broadly include hazard pay for vulnerable essential workers, no consequence paid sick leave policies, and prioritizing minority participants in clinical trials. What can we do as individual healthcare professionals? We can be culturally curious. We can insist on implementation of standardized protocols in accordance with CDC and other guidelines, quality improvement initiatives, especially in facilities that have and serve large minority populations. We can create culturally congruent written and spoken communications and ask and learn about patient social determinants of health, and work with community organizations to help identify and reduce cultural barriers to care. We cannot do this in a vacuum. We really must work with our community. We must also promote and nurture trust and trusting patient relationships by being patient, engaged, and encouraging our patients to ask us questions, and not becoming defensive if somebody has multiple questions to ask about a treatment or a recommendation that is being given. And then finally, we can identify and address our individual unconscious bias that could hinder patient-clinician interactions and communications. With regards to racism in this country and how it interacts with us as healthcare professionals, there are a lot of different ways that you can be an anti-racist ally. The first thing is that action speaks louder than pledges and hashtags and statements. So be sure to augment any of those words with the action. Educate yourself about the history of race relations in this country. Listen to the Black people around you. And if you don't have any, then reevaluate and redefine your circle and find some other people to listen to. Evaluate again, I'm saying it again, your own personal unconscious biases and how they impact those around you. Hold yourself and colleagues and leaders accountable. Call them out when they do things. It doesn't have to be in always in a public and confrontational way, but if somebody says something in a meeting that didn't sit well with you once you sat down and thought about it, speak up and say something. The recognition that this will be uncomfortable work, I mentioned at the beginning of this talk, it's really important. It will be uncomfortable work. And it's also important to not center your discomfort, because at the end of the day, it's not about you, it's about these communities that we need to serve. What about healthcare organizations? What can they do? So each of us can respond as individual allies, but together, leaders of healthcare organizations have the power to catalyze organizational change. And I would consider ACP to be a part of this healthcare organizational change. So what can we do for our communities? We can commit to providing culturally congruent messaging and education across all of our platforms to everybody that we reach. We can support more testing of people in minority communities, insist on providing extraordinary care equitably to all patients, and take appropriate action when this is not done. And ensure and lobby and advocate for essential workers to have access to no consequence sick leave and hazard pay. We can insist that clinical trials prioritize enrolling minority participants and educating people so that they have the full informed consent and informed refusal that is available to them for participating. And then partner with community organizations for testing and prevention. So, for example, Nebraska Medical Center and UNMC as academic medical centers they have an obligation to participate in this change. As an academic medical center, and for any large organization that is associated with healthcare, it is no longer okay to stand in the ivory tower in silence. Our communities, our faculty, our staff, our patients, our friends are looking at us to be leaders in this dismantling of systemic racism in healthcare. Dr. Darrell Gray and colleagues say that academic medical centers, and I would argue also healthcare organizations, need to examine and reform their educational practices and clinical policies and reject race-based medicine like adjusted EGFR or spirometry, as well as commit to funding continuous efforts to ensure an equitable environment. And so for those who might be thinking the system is flawed or it's broken, and we need to fix it so that we can get back to normal, I challenge you to rethink that approach and recognize that, one, the system is acting exactly the way that it was designed. And two, normal is the state we have been in that have allowed a system created from racism and structural inequities. Therefore, the solution must be to dismantle it and completely reset it to one that is meant to be equitable from the start. So ways to reset society, we talk a little bit about some of the things that we can do as individuals as well as healthcare organizations. Here are some other tools that are really going to be important, ensuring that there is equitable access to opportunities in the community so that we can have more diverse healthcare profession is really important. Investing in the community, investing in anti-racist policies, and putting the action that goes with the word is really important. So all of these are things that can be done to reset society. You can scan this QR code for an anti-racist starter pack to help with some self-education and figuring out where your individual areas for growth may be. And most importantly, here we are today, 10 days away from general election, and it is really important for everybody to vote. Think about who are the legislators that are making decisions on your behalf, but also think about the policies themselves. So for example, on the Nebraska ballot this year, in 2020, is a constitutional amendment to remove slavery as a legal punishment for crime. Even if you don't care about specific candidates, racist laws and policies like this lay the foundation for injustice and should be enough to get everyone out to the polls. At the end of the day, we need to care about others who are different from us. We need to care about others who have a different social and economic standing than us. We need to care about people like Breonna Taylor, like George Floyd, like Ahmaud Arbery. We need to care about people who are different than us. If you want to learn more, here's another QR code that you can scan for some selected publications that shared a little bit about the racial disparities from earlier in the pandemic. And there's a great list there for people to follow on Twitter who speak truth to power about both the issues that we're seeing with the COVID-19 pandemic, but also beyond that, with an attempt to try to really enact some structural change. And finally, I'll leave you with some music. I'm from the West Indies. I was born on the island of Dominica, and Bob Marley is one of my favorite artists. And I find it really interesting that Bob Marley wrote a song that to me perfectly embodies our struggles today with attaining equity in our country and in our world. And at the end of the day, until that we can look at everybody and say that the color of their skin is no more significant than the color of their eyes, that we can really truly say that, there will always be war. Thank you.
Thank you, Dr.
Time for questions.
Yeah, thank you, Dr. Marcelin. Lots to consider and lots to think about, and some great resources that you provided that will be good to reflect on at a later date. I'm wondering if you might want to expand upon some of those resources or some of those practical next steps that individuals may want to take to engage in this conversation further, whether that's from a personal standpoint or as they engage with their patients that they're caring for.
It's a great question. So, from a personal standpoint, I think that there's a lot of us who are afraid to engage because we don't want to say the wrong thing. And what I've noticed over the last several months is several people who may consider themselves to be allies being silent because they want to be perfect. And the thing is, nobody's going to be perfect at this. And so I think the first step is acknowledging that you're going to mess up at some point. And so it's more important to speak up and say, if you're in a conference or if you're in a meeting and somebody says something that is disparaging another group or that is very clearly biased, that you say, no, you know what, this makes me uncomfortable. Okay, that sounds, this may not be the way that you intended for it to land, but to me that sounded biased. Or if as a clinician or as an educator, you see that a patient, for example, makes a statement about one of your trainees, that you are in a position of privilege and power as an attending, as that educator, to be able to say to that patient, that is not acceptable. Sometimes it's as the things that one can do to help can be just as easy as asking a patient, what are some of the things that makes it difficult for you to take your medications? Rather than assigning a label of a patient being non-compliant, take the time to ask questions and learn that maybe they only have access to transportation at certain times of day, and the pharmacy that is closest to them is not open at that time. Being open and asking questions is one of the most simple ways, I think, that we can make small individual changes. On a larger scale, I look at our medical students who are doing a lot of great things right now to get that ball rolling of change. And our students were in class and felt like it was not right to be talking about race-based medicine and different, EGFR adjustments. And so they went and they did the research, they looked at the literature, they engaged with experts, and then came to ask for changes in the way that EGFR is going to be reported. And this has been happening across the country. And so I would say look to the example of our students for finding ways that they can ask more questions and keep that conversation going.
There is a question in the chat around looking for opportunities to notice microaggressions and ways to intervene. Do you care to expand upon that at all?
Yeah, so microaggressions are daily small acts of indignities that may happen multiple times to an individual throughout a day that are meant to, whether on purpose or not on purpose, make someone feel small. And so I'll give you an example. My hair is naturally curly, and when I was applying for residency, I was told on multiple occasions by people who meant well that I needed to straighten my hair so that people would take me seriously. So I did, and so for all of my interviews, I straightened my hair. And then sometime while I was in residency, I decided to not continue straightening my hair, and then wore it natural. And then one day I decided to straighten it again, and somebody said, "Oh, your hair looks so professional when it's straight like that." And if you are witnessing that, ways to interrupt those types of microaggressions, which make an individual, once they're receiving it, feel really small, to say, "Oh, what did you mean by that?" I think those words are probably some of the most powerful words that can interrupt those microaggressions, because it forces the individual who said those things to really consider the impact that it might have on someone else. We focus a lot on intent. I didn't mean to be, I didn't mean to say a thing that was racist. I didn't mean to be biased, but we don't realize that regardless of the intent, the impact is still there. And so the first thing that we have to do is recognize and acknowledge the impact, and then think about ways that we could mitigate the intent in a different way.
You provided a lot of great resources. Having not looked at them, that this may be contained, but you mentioned about unconscious bias, which came up in a conversation earlier today as well. And I'm wondering if you've come across any particular resources that help sort of uncover some of those biases that may not be readily apparent to you right now.
Yeah, so actually, I have a paper that there are a lot of good resources on unconscious bias. There's a review or review perspective paper that I recently published last year that was published in the Journal of Infectious Diseases that I can provide to you and Cindy for dissemination to the listeners, that really looks into what does unconscious bias mean, and then talking about some of the places where we may find it. And so it's talking about racial bias. An example of that may be the differential hiring rates of individuals depending on how Black their name sounds or does not sound. Showing that people who have Black sounding names are less likely to be called for interviews and jobs than those who don't, which in and of itself is problematic, because what it has done is led to people really kind of changing the way that they do their CVs and list things on their bios, and even parents naming their children with as the least Black sounding names as possible as a way to protect their children from that bias. And we have gender bias that can manifest in women being passed over for jobs because they are parents and not given opportunities because it's assumed that they are not fit to perform those duties because they also are mothers. Then we have things that we don't talk about a lot, disability bias. And so I would encourage a lot of people to, when you're thinking about bias, to reframe from just focusing on race and ethnicity or gender, and really consider other places where bias plays a role. And so if we think about the way that we communicate, for example, using photos and GIFs or GIFs, depending on which camp you are, for example, on social media, there's a whole group of individuals who are blind or visually impaired who are unable to access any of these if we don't take the extra step to do some things to make sure that they can, like add alternative text to our photos. And that is something that, those are just small things that we can do. And if you want to learn more about that, there's a good podcast there's two podcast examples that I can share. One is the Docs with Disabilities podcast, and that's hosted by Lisa Meeks, who is Dr. Meeks is a disability researcher at University of Michigan, and she's phenomenal. And so that podcast, as well as a recent podcast episode on Explore the Space Show that is hosted by Dr. Mark Shapiro, and he recently hosted a medical student, Harry Paul, who talked a lot about disabilities and ableism, and that's something that I think we all need to learn more about. And then definitely bias as it pertains to the LGBTQ plus community, and use of individuals' pronouns appropriately. And there's a lot of misgendering that occurs because cisgender heterosexual individuals simply don't consider their colleagues and counterparts who may be members of LGBTQ plus community. And so there's definitely a lot of things to consider. And in my article from the JID, we kind of talk a lot about all of these various aspects, and then talk about some of the things that you can do to mitigate bias, like what we've just discussed in the context of interrupting microaggressions, but from an organizational standpoint as well, like ensuring that from the top down, there is an organizational commitment to mitigating bias, to having a diverse workforce, to having open and engaged communication about some of these things, and making safe spaces for individuals.
One last question, I guess before that, it looks like Dr. Shipak found your article and posted it in the chat, so if people are interested, they can link out to that. The last question I think will be maybe giving some examples around how to be culturally curious and sort of the importance of that.
So it is important to be culturally curious. The opposite of that would be making assumptions, and these assumptions are what leads to biased interactions. That's what unconscious bias boils down to, is that our brain makes these fast assumptions of what, who or what a person is or represents based on the sensory input that we have from the media, from things that we read, from what's been told to us by people around us. And so rather than making assumptions, it is really important to be culturally curious, because A, you can learn something about an individual that you didn't know before, but B, it can really help you from a healthcare perspective, it can really help you to pin down certain ways that you can actually help somebody more. So for example, if somebody is one of your patients and they are refusing certain cares, declining cares by the nurses or by other individuals who come into the room, there's two ways that that can be dealt with. One can be with, very dismissive and say, oh, they're just refusing everything. They're a very difficult patient. Especially if this person doesn't speak the same language, if they don't speak English, that would be a very gross misunderstanding of what is actually going on for that patient. So what cultural curiosity means is going into the room and making sure that you have an interpreter that speaks that language and that dialect if needed. And really going the extra mile to make sure that every single interaction is done with that interpreter. A lot of our patients may nod yes, they may say yes or no, or may have just very minimal understanding of English, but they don't actually understand what you're trying to say to them. But they're polite, and so they'll say yes or no. So going into there with that, the culturally congruent language, making sure that that's addressed, and then asking questions about why it is that they are that they have said no to a thing that you would like them to do. So this happened to me recently, and found that a patient who was a patient who was declining a lot of the cares by nursing and was being labeled as a difficult patient. The reason why she was declining cares was because she felt that she was being disrespected. When people would come in and say something to her in English, she didn't really know what they were saying, and then they would undress her. They were trying to clean her up when she had had an accident, but she just felt the horror of being undressed without having any kind of modesty, right? And they felt that they were communicating to her that's what they were doing, but really they weren't. And so if we had taken the time to ask questions, we would have been able to avoid labeling the patient as a difficult patient, and that would have been passed on to multiple nursing shifts to make sure that people were going that extra mile to ensure that she understood all of the things that they were saying. It really makes a difference to our patients when we approach them from that lens rather than from our preconceived ideas of who they may or may not be.
Well, I want to thank you again for giving us lots to think about and some great resources to reference as well.